My Doctor, your health anytime, anywhere.
Hello, lovely people. Welcome to the My Doctor podcast. My name is Mwesigwa Joy and I'm your host. And so for today, we are going to continue with the health law, right? So we're going to look at the legal aspect of health. What are your rights as a patient? How can you reach out for help when your rights have been violated? What does the Uganda Constitution say about right to health? And I'm here with Counsel Sharon. You're very welcome.
Thank you. Thank you, Joy. Thank you for having me.
You're welcome. Could you please introduce yourself to our audience?
My name is Nambozo Sharon. I'm a lawyer. However, on the side, as I pursue my passions, I have a legal advisory business called Avalon Advisory Limited. It provides business advisory, legal and accounting services to small enterprises and also startups. So I'm happy to be here and share my knowledge.
We're also happy to have you because I think most people don't know this aspect of health, their rights and everything. So I think this conversation is going to be very fruitful. So let's dive into the conversation. So before we start, could you please tell us what is the meaning of right to health in practical terms, layman language to the Ugandans?
Okay, I think most of us as Ugandans, as human beings, we believe we have the right to health. We believe it's our right to access healthcare. However, the right to health itself is not explicitly provided for under the Constitution of Uganda. So when you open the Constitution right now, you will not find an article saying, as a Ugandan, you have the right to health. However, there's an article 39, that states that as a Ugandan, you have a right to a clean and safe environment. So from that, we deduce that the right to health is implied, because if you're living in a clean and safe environment, which is a strong pillar for health, I believe that it's implied. However, there are certain things that uphold the right to health, like access to clean water, proper sanitation, adequate nutrition. So we believe that if you have these things, you actually have a right to health. And I believe many Ugandans believe that if they can access these things, they have a right to health. But practically, the right to health for very many Ugandans means access to healthcare. So as a Ugandan, you need to be able to access healthcare from wherever you are, anywhere you are in Uganda. So women, expectant mothers, expect that when they get pregnant, they're able to walk into a healthcare facility and receive maternal care. Also, as a Ugandan, you believe access also encompasses the ability to afford the healthcare. Given our economic status as Ugandans, we believe that healthcare is a human right. So being able to afford it is actually very important, and it goes to the very core of the right to health. Yes. Another thing is adequate financing, healthcare financing, given our incomes. I'm sure even you've interacted with this. The moment you fall sick, the first thing you think about is, oh my God, how much am I going to be charged? How much am I spending on this? So being able to access healthcare financing is very important. But in Uganda, we do not have affordable health insurance. So the government of Uganda is looking into the National Health Insurance Scheme. It has been delayed for so many years, but we believe that once it's implemented, the pooling of resources will make insurance more affordable. So many Ugandans will be able to access healthcare. Another component that is very practical for Ugandans is health equity. Being at the core of health is that it needs to be fair. Access to health needs to be made fair. So very many health facilities are concentrated in urban areas, and people in rural areas usually feel left out because you need to walk very long distances just to access basic health care. Imagine you get an accident in the village in the middle of the night. It's a nightmare to get health care. So it is very important for someone in the village to be able to access healthcare in the same way someone in the urban center would. So this means that the government needs to address geographical disparities by making sure they spread out healthcare facilities in all areas, including remote ones. Yes. So in summary, I believe that is practically what Ugandans believe when they look at the right to health.
Okay, thank you so much. So you talked about the fact that the right to health is not well stipulated in the Constitution, right? So how does the legal system of Uganda address that? Like when we have a problem with right to health, how is it addressed? Yeah.
So I think every lawyer will tell you this. If something is not explicitly provided for under the Constitution, it becomes very hard to enforce. It becomes very hard for you to ask for accountability because you do not have a legal basis. The Constitution of Uganda is the grand norm. It is the supreme law of the land. That's why it's one of the most heavily protected documents, because it lists out our rights that are inherent to us as humans. So the right to health is not explicitly provided for under the Constitution. And this means that there is no proper legal basis for you to hold government accountable for any failures in healthcare. However, like I said earlier, there is Article 39. So even when you do not explicitly read that you're entitled to the right to health, at least you know that when I base on Article 39, I can ask, for some rights, some pillars of healthcare, and also the national objectives and directive of state policy number 14. It also mandates government to provide medical care to its citizens. So these are things that imply under the Constitution that as a Ugandan, you need to access healthcare. However, we've tested this theory and we know that if the law doesn't explicitly provide for it, it becomes hard to compel courts to hold government accountable. This was seen in the case of Sehad versus Attorney General in 2001, where petitioners were petitioning court asking for accountability for the high rate of maternal deaths. However, this case was dismissed. And court cited, among other reasons, that there was no explicit right to health. So even though it was initially dismissed, at least it brought so much attention to the maternal care of women in Uganda and the need to improve that aspect of health care for many women in Uganda. Yes.
Yeah. So since we don't have it in the Constitution, are there any international treaties or regional treaties that influence our right to health as Ugandans?
Oh, yes. So I think as a Ugandan, you may think that, the Constitution doesn't provide for this, so maybe all is lost. No, there are also some local laws, national laws that provide for it. The only problem is the Constitution doesn't explicitly state it, but there is the Public Health Act, there is the National Health Policy. There are so many guidelines from the Ministry of Health that talk about the right to health. But internationally, we are a signatory to very many treaties that highlight the right to health. The very first one is the Universal Declaration of Human Rights, and this talks about human rights as a whole, the inherent human rights that we enjoy as human beings, as Ugandans anywhere in the world. And there's also the International Covenant on Economic and Social and Cultural Rights. So we are signatory to this treaty, and it explicitly mandates governments to provide the highest standard of physical and mental well-being to its citizens. There is also the Covenant on Children's Rights. So this provides mandates governments to provide the highest form of healthcare for children by providing adequate nutrition and good pediatric care in the country. Yes. So there are very many treaties that provide for this, and we are signatory to them. We also are signatory to the Maputo Protocol. Yes. So this provides for sexual and reproductive rights of women. As women, the most important thing for a woman is to make sure that her body is okay. So on top of being a human being, just like a man, we have gynecological care. There are social and economic issues that affect our health, especially our reproductive health. So the Maputo Protocol, among other rights, stipulated these rights. However, when we ratified the Maputo Protocol as Ugandans, the government withheld. There were some reservations. There were reservations on Article 14 that provides for that. In summary, it talks about women having autonomy over their fertility rights and also the right to access abortion care. But as we know, in our penal code in Uganda, abortion is only legal when a woman's life is in danger. Yes, but you know that there are so many reasons that drive women to have abortions that are not necessarily life-threatening issues, but there are also maybe mental issues, societal issues, or even cultural issues, and also even experiences and circumstances in their own homes that drive them to make this decision. But we made a reservation. So what it means is that even though we ratified the Maputo Protocol, we highlighted that section that talks about abortion, and we say, no, this we do not want to be a part of. Yes, so it means that abortion care is hard to access in Uganda, which is and the irony is the government spends around $14 million on post-abortion care. So the government is basically saying that we will not support you to have a safe abortion. We will not make sure you have adequate care when you're aborting. But in case you mess up and complications arise from your unsafe abortion, you can walk into a healthcare clinic and have that complication treated, which is very yes, and ridiculous, because so many young girls, so many teenagers and young women and sex workers are procuring very unsafe abortions and dying very undignified deaths just because the government has turned a blind eye to their plight.
Okay, so I'm going to take you off track a little about the abortions, because I think most people would want to know about this. So if someone has an abortion, like a lady, can they, like, if a health worker helps a lady have an abortion, can someone get arrested in that situation? Is it the healthcare worker? Is it the lady who had the abortion? Is the gentleman involved, because a baby is made by a man and a woman? Who is liable? And
well, now that's a very important question. But when you read the penal code, it means that the biggest culprit is the mother. The woman procuring the abortion is the one who's getting the heaviest punishment. However, the medical practitioner who also conducts the abortion is liable. Now, this brings me back to the discussion about how this is discriminative against women, because as a woman, when you get some women are young, underage girls, and they are having sexual relations that they cannot consent to legally. They cannot consent to. So the fact that they cannot procure an abortion safely and legally is you're condemning them to death. And this person who a male who participated in this endeavor, who probably drove her to have the abortion, is somewhere seated living his best life, because sometimes women have sexual intercourse with men, and these men are telling them so many things, promising them so many things, and when they get pregnant, these people are not willing to take responsibility. So the thought of raising a child alone, there is so much stigma around being a single mother, especially a teenage single mother. So the decision to procure this abortion is driven by the rejection of her male partner. But if she procures that abortion and she's probably arrested, she's going to be culprit number one.
That's not fair.
It's not fair.
It's not fair.
It's not fair.
Anyway, so let's continue with the rights to health. So could you please tell us some of the rights to health in simple terms for the people out there? Like, if I'm a citizen of Uganda, what is my right to health? Okay,
so, the first thing I would like to bring to people's attention is the Patient's Charter. So the Patient's Charter was first introduced in 2009, and it was later reviewed to form the Patient's Rights and Responsibilities Charter in 2019. So in short, this highlights, just like the Charter states in its title, it states the rights of a patient and the responsibilities of that patient. So as a Ugandan, you need to acquaint yourself with the Patient's Charter, because it highlights your rights as a Ugandan when you're accessing healthcare anywhere in Uganda. So the first thing is the right to informed consent. So very many people know that they have the right to say yes or no when asked to do certain things at a hospital, treatment treatment options, alternatives. So most people know that they have the right to consent, but most people do not know that they have the right to informed consent. So the word informed in informed consent basically highlights the fact that as a patient, you have the right to have information. The practitioner has to give you information regarding your illness. So you need to have information regarding your diagnosis, the treatment plan, the implications of that treatment, any side effects, if any, are there any alternatives, such that when you make your decision and you're saying, oh yes, okay, I would like to undertake this form of treatment, it is coming from an informed place. You have accurate information, you're agreeing to the consequences or side effects, if any, so you're making a decision from an informed basis. Another right would be the right to confidentiality. We have the Data Privacy and Protection Act of 2019, and this act basically highlights confidentiality of information of subjects. So under this act, it is provided for that if you're in possession of someone's information, especially personal identifying information that can identify someone, you need to keep that information private and confidential and only share it with a third party with the consent of the data subject. So it means that as a patient consuming healthcare, when you walk into a hospital, you're entitled to privacy of your information and medical records, and this information can only be shared with a third party if you consent to it. Yes. So information about your illness, the treatment plan, your age, or any other circumstances that can identify you, they need to be kept confidential. Another thing is that as a patient, you have the right to be treated by someone who you know, who you can identify. So a healthcare provider needs to have their name on display, such that if they ask you, Joy, do you know who is working on you? You can say, oh yeah, Nurse Sarah came in, or Dr. David came in. So you need that is also your right. You also have a right to access healthcare without discrimination. And this is very important. I feel like people from marginalized communities like the LGBTQ, this is something that they can understand, and it resonates with them, because there are people who have been denied healthcare because the healthcare provider probably has religious, cultural, or even personal beliefs regarding the experience of this sexual orientation, and they deny to give you healthcare. So discrimination is not allowed under the patient's charter. So if as a patient you experience this, at least you know you have recourse. You have recourse to it being you have recourse to redress, because the charter clearly states that there won't be any discrimination along sex, age, tribe, or even sex orientation. So that patient's charter in its entirety stipulates very many rights, but in short, those are just the ones I can highlight for you right now.
Okay. So you talked about informed consent. What types of informed consent are there? If I'm a health worker, can I get informed consent verbally, or I'm supposed to make sure the patient signed somewhere? Yeah, and also in terms of emergencies, right? A patient has come, they are bleeding, it's trauma, they have fainted, there's no one around. Can I just do the procedure because it's an emergency, or I have to make sure I find someone I know to give me the consent?
Well, for informed consent, there are three types. So number one is that a healthcare provider can procure consent verbally or in writing. Okay. So a doctor can talk to you and then procure your consent verbally. But then the levels of consent go higher when the stakes also rise. So for example, if you're being asked whether you should take Panadol, you know, that's for me qualifies like level 1. But there are higher standards, higher levels that require consent to be in writing. Okay. Especially procedures, human experimental procedures. You're experimenting on new medicine on humans, or alternative health alternatives on a human being. Those require written consent. In emergency situations, now these are the situations where someone can give treatment without consent. Because imagine someone has an accident and they're bleeding profusely. They're in so much pain, or they're even unconscious. So the state of this person, they are unable to give you informed consent. When you're in pain, you're not thinking straight. You're not thinking straight. Trust me, the doctor may explain everything to you and you still won't understand it because you're in pain. If they ask you right now, okay, so you're in pain, you're bleeding, should we administer morphine or fentanyl or anything? The first thing yes, because you're bleeding. You're bleeding, you're in pain. So in such situations, actually the patient's charter talks about it. In emergency situations where a healthcare provider cannot procure consent at that time, they can procure it later. Or they can procure it from your next of kin. Sometimes you walk in with a guardian, or in situations of a minor. Minors cannot consent, but their parents can consent on their behalf. Yes, so when your child is sick, the law presumes they cannot consent. So a healthcare provider can't say, oh, I talked to the child and the child said this. No, the parent will consent on the child's behalf. But if you're in an emergency situation, the doctor will administer the treatment and later explain to you exactly what he did and get your consent at that time.
Okay, so let me take you to the children for a bit. So there's something I read about called Gili competence. I don't know if it applies in Uganda, where a child, like for example, a 16-year-old can come to your fertility clinic and they want contraception. So, and since if you're sure they understand what they're asking for, then you may be allowed to give it to them. Does that apply in Uganda? Like if a child is understanding mentally and they want something for themselves, because a child cannot tell a parent, I want contraception, but they have come to my clinic, they are 16, and if I don't give it to them, they're going to engage in sex and get pregnant or something, or STDs. So am I allowed to?
Well, unfortunately, the penal code is very clear, and also the Constitution. A minor is anyone below the age of 18. Persons below the age of 18 cannot consent, and also the penal code also penalizes child-to-child sex. Because they cannot consent. So you cannot say, oh, because I'm 15, I had sex with a 15-year-old boy. We are both minors. It's still a crime. When this child has sex with a person above the age of 18, it's defilement. So the law, by default, it presumes that anyone below the age of 18 is not supposed to be having sex. So you cannot walk into a pharmacy and procure contraceptives when you're below the age of 18. So if someone is procuring contraceptives below the age of 18, you're doing it under the counter, under the counter transactions. And this is a problem with us as a society and also with our laws, because we know that people below the age of 18 are actively having sex. We know that they're engaging in sexual activity. This is something that dominated the media, especially during COVID-19. There were so many teenage pregnancies. It means that these people who are below the age of 18 are having sex. So it means as a society we need to adjust, because the world around us has also adjusted. These people are going to have sex whether you say yes or no. It's our duty as Ugandans, as adults, as people, as older people in society, is to make sure that this sex is safe, such that we prevent unplanned early pregnancies, teenage pregnancies, and other complications that arise from that. And also, secondly, the sex is safe, such that your child doesn't make a mistake at 14 and procure a sexually transmitted illness they will have to carry for the rest of their life, when a simple use of a condom would have stopped that. So I feel as a society, we need to adjust. We need to wake up to the realities of our children and realize that these people are going to have sex. So we need to find modern ways to make sure that this sex doesn't become a problem and cause permanent issues to them later in life.
Okay. So we also talked about confidentiality still on the children. So in a scenario, for example, a child has come to me, 16, let me say 16, and then we make an HIV test. Probably they've been engaging in such activities and they're positive. And the child tells me, do not tell my parents. Who do I owe the confidentiality? The child, but they're under 18. Because the child has said, doctor, don't tell mommy. I'll tell her myself when I'm ready. So what do I do? But then parents may need to know because they're living with her and she's a child. So who do I owe the confidentiality? Child, parent?
I think you owe both, because we know if you think about yourself at 16, there are things that you kept from your parents and there are things that were important to you as a child. You owe both. As a medical practitioner, you owe both confidentiality in the sense that when you're delivering this information to her parent, because like I said, below the age of 18 you are minor. Consent is only procured by your parents. But I believe that healthcare providers are trained on how to deliver information of this kind to parents and also handle situations where a minor is probably in this situation. They're infected with HIV and they are fearing disclosing this information to their parents. So you need to disclose this information because you see, confidentiality is one thing, but disclosure is something the law provides for. Number one, you can disclose information by a court order if a court order requires it. Also, if it's required by law. So by law, you are obligated to give this information to someone's parent. Okay. But I personally, I would, if I was a healthcare provider, I would exercise discernment. Personally, I would exercise discernment.
Okay. Then still on the confidentiality and privacy, yeah? We know in Uganda, some of our facilities are overcrowded. In the rural areas, they have one facility for like a whole district. So, and then sometimes the issue of privacy is hard because let me give you an example of labor ward. Like you go to like a labor ward and all the women are in the same labor ward. This one is giving birth, this one is giving birth, this one is giving birth. So how can we handle the privacy and confidentiality in a place that is overcrowded because it becomes hard sometimes?
Well, I will not sell Ugandans fantasies because I'm sure many of us have walked into situations like this because there was a report, I think it's 2022, by Action Aid that said that the healthcare centers in rural areas where there was so much overcrowding and there were no maternity wards. There were not enough to cater to the number of mothers. So very many women were giving birth on hospital floors. So I would not want to sell anyone a fantasy because this is a reality. It's a Ugandan reality. Very many mothers are giving birth on hospital floors and people are getting treated in hallways. I've seen it happen, especially when you walk into a public hospital. You will see people getting treated in a place where you can see them. But most importantly, healthcare providers are not the enemy. We know that they're also providing a service in a broken system. So they'll do so much, but there is, that they are limited by the resources available. So a healthcare provider may make adjustments given the circumstances because we cannot magically increase the space or create extra room for someone to get privacy. But in situations like that, healthcare providers are employed to make adjustments, So for like a mother, giving birth and there is no space, they usually put curtains. You may not get your room where you can enjoy your own privacy, but at least a curtain separating the two beds, that is something that you can do. Also creating maybe one consultation room whereby someone can walk in, do their consultation, and then walk out and maybe receive treatment from elsewhere. So they can make do with the resources that are available, even when I know that, there's a limit to how much can be done when the resources are inadequate.
Okay. So I think that falls partly under discrimination. Right?
Yes, because this is something that mostly people in rural areas experience.
Yeah. So how do you think we can, is there a way we could solve it as Ugandans? Is it the resource limitation, the doctor to patient ratio? Is it the facilities? What could be wrong?
Well, if we start to talk about what's wrong with Uganda's healthcare system, we'll talk till the cows come home. But there's so much that is wrong with Uganda's health sector. There is so much. But the most important thing is we'll start with government. Because government has the mandate. It's its responsibility. That is their job. Our health as Ugandans should be their topmost priority. However, only around 6.5% of the national budget is allocated to healthcare. And only about 1% of the health budget is allocated to mental health. So now that should tell you. And yet the Abuja Declaration basically stipulated that governments should provide at least 15% of their national budget to the health sector. So you can see how far we are from 15%. If we're only, investing 6.5%. So it means that the resources are very limited. There are reports of healthcare centers that don't have maternity wards, they don't have enough beds, the incinerator is broken. So there is the resource factor, the money, the funds, that is very important. So we can start there. The government needs to invest more in the health sector. And also this investment needs to be equitable. So at the core of this investment, it needs to be fair, because there is a very large divide between rural and urban areas. The people in rural areas, I'm sure, feel forgotten. So as they increase resources in the health sector, they need to allocate them to the biggest pain points, especially remote areas, rural areas where people are walking very long distances to healthcare facilities. And that is something that government can do. They can also partner with international organizations such that they can probably bridge that funding disparity. But the problem with that is that we already know what is happening currently with funding. So over-reliance on funding, on external funding, is also a problem. But that's also something that could be a solution, because as we know, healthcare largely in Uganda is funded, especially for minorities, sexual minorities, vulnerable groups, those key populations like sex workers, refugees. Most of the people funding these special groups, they're international bodies and civil society, NGOs. So partnerships with these people can help bridge that funding divide. Another thing would be, as Ugandans, there's something we can do. I believe digital health, e-health initiatives, that's something that is very important if you're trying to bring some solutions on board. Because when you create a digital health solution, for example, if you create it with the rural population in mind, you create maybe an SMS-based solution, because most people in the rural areas do not have smartphones, but most of them at least can access button phone, those feature phones, such that they can do a few USSD codes and then be able to access consultation with a doctor, and also make an appointment to make an appearance at a health facility, such that someone doesn't leave their home on Monday, walk to the health facility, reach there maybe in the evening, are unable to see the doctor, and then they are told to spend the night. They did not plan for accommodation, they did not plan for feeding, they do not have that money. But if they stay in their home, consult a doctor, and then make an appointment, and approach and when the date approaches for their appointment, they make their way to the health facility and actually receive audience from a healthcare provider. That saves a lot, it saves a lot. So there's no back and forth, there is no frustration on the end of the patient. So I believe as Ugandans, because on the market, I also know my doctor has a digital health solution. So and it's targeting those people, the vulnerable people, people who are from low income households, people in remote areas. And even when you're not in a remote area, but you live in an urban center, and let me say you have a medical emergency at 3 a.m. chances are very high at 3 a.m. you won't be able to get audience with a doctor. But if you have an e-health solution, you can consult a doctor 24/7, make an appointment and get attended to. So I believe as Uganda, this is something we could look into, invest in these solutions. Another thing is we should educate the public. We should educate the public. Sensitization of communities in rural areas and even in urban areas can bridge the information gap between urban and rural areas. Let them know their rights, educate them on the Patients Charter, make this information available to them such that they are more empowered to make decisions that affect their health, and also hold health workers and government institutions accountable for failures in the health system, but also demand for more. When someone understands their rights, they understand what is due to them, they have a very strong basis to advocate for their rights and demand for more from the relevant authorities.
Okay, so let's talk about the rural areas, more. So there's something called cultural stigma towards access to healthcare. It was more prominent, I think, in the old days, but do you think it's still around, and what can we do to change it? Are there some cultural stigmas associated with access to health?
Yes. We live in a patriarchal society. So I think as long as patriarchy prevails, we shall never be rid of cultural systems that hinder progress and create discrimination. So yes, I think I'll categorize the different stigmas. I'll start with the stigma around mental health. So I think this is something we've seen, all of us as Ugandans. There is that person who is suffering from a mental illness that you can remember from your childhood, or even that right now from your village, and they would tell you, oh, you see, that person was cursed, or it was a spiritual solution gone wrong. They consulted a witch doctor and maybe it went wrong. It's the belief, the cultural stigma around mental health, the belief that someone who's suffering from a mental illness is either punished, it's a punishment, or they are cursed, or it's a personal failure on their part, creates a stigma that is so dangerous, because families actually hide away children suffering from mental illness. There's so many times when you look at the news stories that you see a child suffering from either maybe physical or intellectual disability being kept, and tied up, So they hide you away from the public because they look at you as a shame. They look at you as a stain on their white. So that stigma, viewing these people as a problem, it also hinders adults who are suffering from either psychosis, anxiety, or depression. It hinders them from accessing healthcare facilities because of the fear of being ostracized by the community. Yes, the discrimination you face when someone the fact that even someone thinks you have a mental illness, it stops so many people from being able to speak up about it or even approach a healthcare facility to have it treated. So another stigma is the stigma around HIV/AIDS. This is a stigma as old as our regime. So the stigma around HIV/AIDS is so old, and it is still prevalent up to now. And it's one of the reasons that have hindered our progress towards an HIV-free generation. Because very many people believe that if someone is suffering from HIV, the very first thought is that you're promiscuous. Yes, so HIV is looked at as a punishment. You are promiscuous, you're probably unfaithful, you slept with so many people in your life, and that's your punishment for what you did. And this leaves out so many people who acquired HIV from rape, who acquired HIV from mother-to-child transmission, hospital blood transfusions, unsafe equipment. All these people are left out, and they are all reduced to one thing: promiscuity. Yeah, so the stigma around HIV/AIDS. Now, this is very dangerous because it hinders people from accessing healthcare facilities and tests screen for HIV early, or even walk in there with their spouses or sexual partners to get tested. And also people, the stigma around it stops you from getting treatment early. Acquiring HIV and starting antiretroviral therapy early on in your life gives you a chance at a healthier, longer, fulfilling life. But when someone acquires HIV, get tested, and they find out, oh yeah, I'm positive, someone starts thinking, where am I going to put these antiretroviral drugs? Where am I going to hide them? Yes, because you have actually, even personally, I've actually never seen antiretroviral therapy drugs. I've not seen them because you can't know. People are going to hide. They will hide this from you. They will hide it from the very people who could have helped them because of the stigma, the belief that they are being punished or they need to hide this condition. So most of us only know ARVs from TV, or even maybe when you go to a healthcare provider and they're counseling you or even explaining to you. So that causes a big problem because it means that people keep on, transmitting this illness to other people, and it causes, so much problems.
Sorry, and the interesting part is we even have PEP in Uganda, but still people are scared to go and ask for it, yet it could have saved you a lifetime.
Yes, because when you want to get PEP, actually there are screening questions the healthcare provider will ask you. None of them are discriminative. None of them even point to the fact that maybe you this is it's a punishment or it's wrong. But the moment someone needs PEP, or they feel like, oh, I've engaged in unsafe sexual intercourse with this person, I do not know their HIV status, the first thing they think about is, how am I going to be perceived? Those few minutes you're interacting with a healthcare provider, speaking about your circumstances that require you to get PEP, someone is thinking, oh my goodness, this person is going to think I'm a prostitute, I'm a sex worker, what did I do to get myself in this position? And yet PEP is supposed to be a preventive measure, 30 days of your life versus, the rest of your life on ARVs. So there needs to be a lot of sensitization to combat this stigma. Yes, another stigma is around disabilities. Now, people suffering from disabilities, physical disabilities, intellectual disabilities, these people suffer the same issues as people who are mentally ill. Because people in their families, in their communities, look at them as a problem, as an embarrassment. So so they hide them away, or they don't modify their living situations to accommodate these new conditions. For example, creating easy access to the house or easy access to the health center, something as simple as a ramp. Up to now, there are some healthcare centers that don't have a ramp, because and that is a blatant statement saying that you're not welcome here. Because if you're lame and you're using a wheelchair and you cannot access a health facility, how will you feel welcome when you're inside it? It means that it wasn't created with you in mind. Yes.
Okay. Then, as we come to the end, as we wrap up everything, what role can lawyers play in the right to health in terms of advocacy, or in terms of someone feels like their right to health has been violated? What role can the lawyers play, and how can they help us?
So I think lawyers individually. Lawyers can represent, persons who have suffered from healthcare violations of their rights. They can, so for example, if you've suffered from discrimination, denial of treatment, or even medical negligence, that your go-to person should be a lawyer. You need someone who will file these proceedings against the specific healthcare provider, or even the institution that has violated your rights, such that you can get redress from court. Another thing would be lawyers can file complaints to bodies that oversee the work of health workers, institutions like the Uganda Medical and Dental Practitioners Council. Complaints can be made, and maybe disciplinary action can be taken. Lawyers can also hold the legal literacy workshops where they go into the community and teach people about their healthcare rights, teach them about the patient's charter. because it has the rights of the patient and the responsibilities of this patient. So they can go into the community, they shouldn't use legal jargon, simplify the law as make it as easy as possible. Use visual aids, pictures if you need to, or even use role play if you need to, such that you make this information as accessible, easily understandable as possible. These people can also use strategic public interest litigation. So lawyers can, and this is something they've also done in the past, lawyers can strategically initiate litigation against public bodies, against institutions, in the interest of public, such that they can, like the Sehad case that I quoted versus the Attorney General. This was a case questioning, asking for accountability for maternal deaths. So they can initiate strategic litigation, public interest litigation, such that they can create precedents, that other judicial officers can lean on, also bring awareness to certain issues. Lawyers can also collaborate with civil society, international bodies, regional bodies, and also they can escalate violations that did not receive redress domestically. You can only benefit from an international treaty if the treaty has been fully domesticated in Ugandan law. So sometimes those treaties are not. We haven't implemented them here. So despite their very ideal values on the right to health, you cannot enjoy the rights therein. So what helps is that lawyers can actually directly escalate these matters to these bodies, and if they don't get redress domestically.
Okay, thank you so much, Council Sharon. I'm sure our audience has learned a lot. So as we come to the end of the episode, I'm requesting you to talk to the people. What message do you have to the policymakers, the healthcare providers, and the community at large on how we can enhance our healthcare and the right to health?
Well, I think I'll start with the policy makers, because I believe that is where the solutions lie largely. So to the policymakers, I'd like to implore you to escalate legislation that creates equity in healthcare. So number one would be to implement the National Healthcare Insurance Bill, to implement it such that the scheme such that people can easily access health insurance at affordable rates. The pooling of resources between the different sectors, different people from Uganda, will create affordable healthcare insurance for Ugandans, such that people do not have to spend out of pocket for complex procedures and very expensive procedures. Another thing would be to create legislation that is favorable to marginalized communities and vulnerable communities. We currently have an anti-homosexuality act that affects the rights of people in the LGBT community. So this is a problem because it furthers stigma around these people. It furthers their discrimination and prevents their enjoyment of their rights, and escalates diseases like HIV because of the stigma. And lastly, I would like to implore that, policymakers work together with NGOs and other people in international organizations, such that they can bridge the disparities, in healthcare. For example, Maristops, that provides sexual and reproductive healthcare to young women and young youth in Uganda. So these collaborations can help bridge the gap such that they are there where you're not. Then to communities, I would like to ask people in communities to know and demand for their rights. Acquaint yourself with the Patient's Charter that contains the rights of patients and their responsibilities when they're interacting with a healthcare provider. Strengthen your collective voice and advocacy in your community, such that you can demand for your rights, such that you can hold government and institutions and even health workers accountable for their failures. Yes. What else was it? Communities, yeah. So communities, know your rights and demand for them. Yes.
Okay, thank you so much, Councillor Sharon, for your time. I'm sure Ugandans have learned a lot about the right to health. Policymakers are going to hopefully work on some things that we have talked about, and also the healthcare providers. So thank you so much. Then to our lovely people, hope you've learned a lot. We've learned about the right to health. You have a right to a non-discriminative healthcare system, confidentiality, informed consent. Let's clear out all the stigmas that we have talked about. HIV stigmas, mental health. Let us work together to make our healthcare system better for all of us here. So thank you so much for watching this episode. This is the My Doctor podcast. We'll be airing every Saturday. We'll be having episodes every Saturday on our YouTube channel, My Doctor Podcast. So stay tuned. My name is Mwesigwa Joy. I am your host. This is a My Doctor podcast. My Doctor, your health, anytime, anywhere.
My Doctor, your health, anytime, anywhere.